going through whatever is there, how to detect the severe acute malnutrition, SAM. ঠিক আছে, এই কথাটা যেন মাথায় থাকে, whenever you have to diagnose a child you are saying SAM, severe malnutrition, acute malnutrition, আধখ্যাচটা টার্ম যেন কোথাও না থাকে, SAM, severe acute malnutrition. So now how will you see or detect such cases in the community? Severe acute malnutrition is a form of PEM. PEM মানে কি? Protein energy malnutrition. তাই তো? Then for example, if we take a data or a case going in the community, কি case? এখানে একজন 5 years old একটা male child আছে, okay? Birth order first, mother father name দেওয়া আছে, address rural area. According to his mother, complaint কি আছে? His son didn't attain height and weight for his age. 5 বছরের বাচ্চার যত হাইট এজ ওয়েট হওয়া উচিত সেই অনুযায়ী ডেভেলপ করেনি, এটা প্রাইমারি কমপ্লেন্ট ইউজুয়ালি হয়. দিস ইজ ইউজুয়ালি দ্য প্রাইমারি কমপ্লেন্ট, ওকে? It was the case was apparently well at the age of 1 year. 1 বছর যখন বয়স ছিল, he was apparently well. Then his mother noticed that he didn't gain weight. Weightটা gain হচ্ছে না. Then she consulted a private practitioner at the age of 1.5 years, but in height and weight didn't get increased. So after that she didn't consult any doctor. ওইভাবেই আছে চাইল্ডটা, এখন তার 5 years হয়ে গেছে, almost 5 years, and the child hasn't gained any height and weight. Past history, no hospital admission, no history of any infectious disease like pneumonia, TB, malaria, kala-jar, jaundice, asthma, no past surgical history. Okay, so this is a history that a child with PEM usually presents with in the milder forms of the PEM. The general information কি নিলে? Name, age, sex, date of birth, birth order, name of mother and father, religion, address. ঠিক আছে? Because age এর উপর ডিপেন্ড করে, then there is gender, there can be psychosocial problems in the community like gender bias, okay, nutrition sometimes are not given adequately to girl child, এরকম অনেক কন্ডিশন থাকতে পারে. বার্থ অর্ডার যদি মোর আফটার হয়, মানে 4, 5, 6 যদি বার্থ অর্ডার হয়, সেখানে ম্যালনিউট্রিশন হওয়ার চান্সেস বেশি, রাইট? ওকে, তারপরে অ্যাড্রেস, রুরাল আরবান এরিয়াতে ডিসপ্যারিটি থাকতে পারে. চিফ কমপ্লেন্ট অ্যান্ড হিস্ট্রি অফ প্রেজেন্ট ইলনেস, usually there is failure to gain weight, then there can be danger signs. In this case there is no danger sign as of yet, but there can be danger signs like convulsion, unconsciousness, inability to feed or drink, lethargy, vomiting, etc. ঠিক আছে? So all these cases can happen. And আর কি হতে পারে? What are other diseases that the child can present with? There can be ARI. In the recent present, there can be a history of ARI, okay, diarrhea, fever, cough, ear discharge, recurrent infections, worm infestation, etc. Then loss of appetite, swelling of feet. So all these complaints can occur in the child, usually an under 5-year-old child. Past history ki thakte pare? If there is hospitalization, surgery, then other infectious diseases, chicken pox, measles, tuberculosis, or any contact of a known tuberculosis case, that is past history illness. And treatment history, history of admission in an NRC. What is an NRC? Nutritional Rehabilitation Center. NRC কথাটা এখন শুনে রাখো, we will come to that later again. NRC is Nutritional Rehabilitation Center. Any Anganwadi center is nearby or not, whether the child is registered there. What is Anganwadi center or ICDS center? কিছু আইডিয়া থাকলে বলো. প্রি স্কুল এডুকেশন, নিউট্রিশন, সাপ্লিমেন্টারি নিউট্রিশন যেখানে দেয়, ইউজুয়ালি এখানে খিচুড়ি স্কুল বলে সবাই জানে, খিচুড়ি স্কুল, ঠিক আছে? ইট ইজ আ আঙ্গনওয়াড়ি সেন্টার অর অ্যান ICDS সেন্টার. ICDS বেসিক্যালি ইন্টিগ্রেটেড চাইল্ড ডেভেলপমেন্ট সার্ভিসেস, integrated child development services, that is ICDS. Okay, so that child visited any Anganwadi center or ICDS center or not? What is the frequency of attending there? Why am I taking this history? Because it takes the history of intake of supplemental nutrition, intake of any drugs, if in the case of any ARI, then also receipt of immunization. Anganwadite ki hoy or ICDS center e ki hoy, the beneficiaries like these children, okay, they receive the preschool education, that is below 6 years of age school education hoy, okay, they are registered there and they receive preschool education by the Anganwadi workers who are there, okay, then they receive the supplemental nutrition, protein and calorie, then there is immunization services, common illnesses and others, those are checked, okay, and other diseases like any referral services also are there. So Anganwadi center, this is not like a PHC or a CHC, it is not a health center, it is not coming under the Ministry of Health and Family Welfare, this ICDS or Anganwadi center, it is coming under Ministry of Women Empowerment, okay, and under that the Department of Education. So under that Ministry of Women Empowerment, that is the Anganwadi center is registered. So not only under 5 children but other beneficiaries can also take help there, like the pregnant mothers, lactating mothers, okay, then there is adolescent girls and boys, they can also take the services, the nutrition from there. So it is very important in case of child to know whether there is any history or not of attending the Anganwadi center, and if not, if they are not attending, then why. Then comes the feeding history. So feeding history of the child from the birth, okay, from the birth we have to take the history, that is after birth, what was the time of initiation of breastfeeding, when did the breastfeeding start for the child, okay. It should be as soon as possible after delivery, okay, ideally within 1 hour, in case of C-section and within 30 minutes in case of normal vaginal delivery, ideally. So immediately after birth, as soon as possible the breastfeeding should start, that is called the early initiation of breastfeeding, EIBF, early initiation of breastfeeding. So you have to take the note, what is the time of initiation of breastfeeding for the child, then whether colostrum was given or not, okay. What is colostrum? Within the first 1 to 3 days, the thick yellowish milk that is there generated by the mother, it is rich in immunoglobulins, proteins, etc. Okay, so that is helping in the antibody. This is indirect passive immunization given to the child at birth, that is rich with immunoglobulins that protects the child from any diseases. So colostrum should be given. Then frequency of feeding, how many times was a child fed during breastfeeding, okay, whether there was either child was fed less or child was fed adequately. What is less? This any time the child is demanding if they are not fed, okay. So usually the frequency of feeding should be on demand feeding should be there, সবসময় on demand feeding দিতে হবে, okay. যখনই child will cry, the mother will feed him or her, okay, and the child usually takes 10 to 12 feeding per day during the daytime, and at night also the child should be woken up and fed 4 to 5 times, night feeding, তখন বাচ্চা ঘুমাচ্ছে হয়তো, ঠিক আছে, কিন্তু তাকে জাগিয়ে তাকে খাওয়াতে হবে 4 থেকে 5 বার, that is night feeding. Sometimes there is day feeding but absence of night feeding, that can also cause malnutrition. Then any prelactial feeding, what is prelactial feeding? Prelactial feeding মানে হচ্ছে before the milk was given to the child, whether anything other than milk, breast milk was fed to the baby or not. যেখানে অনেক সময় মধু দেওয়া হয়, চিনি দেওয়া হয়, in those cases prelactial feeding is recorded and that is not the recommended, okay. Prelactial feeding should not be there. For the first 6 months of life, the baby should take only and only mother's milk until and unless recommended by a doctor, যে কোনো মেডিসিন নিতে হবে. Other than that, not even water should be given to the baby. Only mother's milk should be given to the baby for the first 6 months, because the gut of the baby is not developed that much, gut is still developing. So anything other than mother's milk can cause any infection, high chance of causing infection. Then here written no exclusive breastfeeding means the child, the case was not exclusively breastfed, but for 6 months there should be exclusive breastfeeding. Okay, এটা মাথায় রাখবে, for the first 6 months of life there should be exclusive breastfeeding, only mother's milk should be provided to the baby. Mother's milk has everything in them যেটা আমার বেবিকে নিউট্রিশন প্রোভাইড করতে পারে, ওয়াটার থার্স্ট মেটানোর জন্য প্রোভাইড করে, এভরিথিং ইজ দেয়ার ইন দি মিল্ক, ইন দি ব্রেস্ট মিল্ক. Okay, top feed started from the 3 months of age in which cow milk was given. Top feed means anything other than the milk, any other type of milk. Okay, because why not exclusive breastfeeding this child was given? Because top feed was started from 3 months of age in which cow milk was given. Cow milk has more higher quantity of protein and other types of amino acids casein which is not digested by the child, by human child. ঠিক আছে, cow's milk is good for cows, human milk is good for humans. Okay, either milk cannot be digested by the child below 6 months. And bottle used and was cleaned by boiling. Okay, so this is the history of that child, that there was absence of exclusive breastfeeding and this whole feeding history was taken. Then there is the birth history. Okay, birth history means whether the child was term or preterm. Okay, then what is the birth weight, whether the child was low birth weight or normal birth weight. What is low birth weight? আমি কখন বলবো the child has been born with low birth weight? Less than কত? 2.5 kg, 2500 gram, less than 2500 gram or 2.5 kg is considered to be low birth weight. Okay, so what was the birth weight, what is a birth order, means which number child is that in the family. Then type of delivery. Okay, normal vaginal delivery or C-section or forceps. Then place of delivery and delivered by, whether it's an institutional delivery, if institutional delivery, delivered by whom. Okay, whether there was any complications during delivery, etc., or whether it was home delivery. Then crying after birth was present or not, any incubator or this NICU needed, any intensive care was needed or not, and any congenital anomaly was present in the child or not. So all this birth history was taken. Feeding history I have already told, time of initiation when it was given, colostrum, prelactal feeding, exclusive breastfeeding, any history of bottle or artificial feeding, anything other, any milk other than mother's milk was given in the first 6 months or not. And after that, when did the complementary feeding start? That is, at the end of 6 months, the baby now starts to take some other food other than mother's breast milk. That is complementary feeding. Before it used to be called weaning, now it is termed as complementary feeding. So complementary feeding, it should be started after 6 months. Okay, it should not be started before, it should not be started much later also. Okay, because after 6 months what happens is the mother's milk is not adequate, no longer adequate nutritionally for the baby, and the baby's gut has also developed. Now they can take the food from outside. So that is why around at 6 months the complementary feeding should start. What was fed, the nature, amount and frequency measured by spoon or katori or this bowl. Okay, so how much feeding was done from the for the child. In অন্নপ্রাশন হয় 6 মাসের বয়সে বাচ্চাদের, that is the initiation of complementary feeding. তো কি কি খাওয়ানো হচ্ছে বাচ্চাকে, what is the food that is given to the child. Okay, usually it is started by mashed food, semi solid food with little bit of oil or any dense energy rich oil added in it, like ঘিও add করতে পারো, oil add করতে পারো, few drops to make it energy dense. Okay, because energy should be provided to the child more at that age. Then whether hand washing practices are practiced by, hand washing practices are provided by the mother before or not. Okay, after preparation of food or feeding. So hand washing is very important, so that it is seen that no other forms of contamination or infection is spread to the baby. Then comes the immunization history. We have to check for the BCG scar, whether the BCG scar is there or not. BCG, what is BCG scar? ওটা কিসে, what is BCG scar? That is the scar that is formed upon application of BCG vaccine. When is the BCG vaccination given? At birth. At birth. BCG vaccination is given at birth. At birth, 3 vaccines are usually given. The BCG vaccine, okay, the OPV vaccine 0 dose, oral polio vaccine 0 dose, 2 drops, okay, that is termed as 0 dose, it is birth, and hepatitis B vaccine birth dose, Hep B vaccine birth dose, okay, that is given as an injection. So both BCG, OPV 0 dose and hepatitis B birth dose, these 3 vaccines are given immediately after birth, okay. So for this child, under 5 child, you are taking history, you have to check whether there is BCG scar or not, and any MCP card is provided or not. MCP card means the mother and the child protection card. A card is given to the mother when she is registered during pregnancy at a center, health center. She is given a green booklet basically. In that booklet, all the advice and all the records regarding her antenatal care, all the records of her pregnancy, then thereafter the record of birth and the details of the child, the birth weight and everything is recorded there, including both the vaccination of the mother and the child. So all the records are recorded there in the card. So if you have the card, if you can see the card, then you can see whether which vaccines have been given to the child till date, okay. So MCP card availability on is there or not. Immunization status, okay, what is the immunization status of the child, whether the child has been vaccinated up to date or not. Then reasons for delays, if there is any delay in vaccination, what are the reasons for the delays, and history of AEFI means any adverse events following immunization or not. Adverse events following immunization or not means if there is any adverse event related to immunization, like any anaphylactic reaction, etc., or any fever or any abscess development like that. So this immunization history is important because if there is any missing in immunization, that means there is a high chance of infection in the child, and that can lead to malnutrition. This infection and malnutrition is locked in a vicious cycle. If there is infection, there is high chance of malnutrition. If there is malnourished child, then there is high chance of infection, like that. So this immunization history is also very important, and personal history like sleeping pattern, bathing habit, bowel habit, bladder habit of the child, allergy and type of diet taken. Then you can take the ANC history, antenatal care history, that is whether the mother registered, whether the mother received her vaccination of tetanus, then IFA and calcium supplementation was given to the mother or not, that is iron, folic acid and calcium supplementation was given to the mother or not. How many ANC visits did the mother do in the hospital, how many times did she visit during her pregnancy, any complications are there or not, like hyperemesis, preeclampsia, eclampsia during her pregnancy, whether there were any complications or not, antepartum hemorrhage, and investigations during pregnancy, what was the report of her hemoglobin, whether it was low, what was the report of her viral antigens, whether she was HIV positive, HBs, hepatitis B positive, blood grouping, what is the blood group, okay, what was the blood sugar, etc. And intranatal, this intranatal place of delivery, delivered by doctor, we already know it was around the child, cried immediately after birth, no history of postpartum hemorrhage, what was the birth weight postnatally, then born at full term, when was the birth, term or preterm, at the turn or before the turn. When do I tell as preterm and when do I tell as term? What is the duration, usual duration of pregnancy? 37 to 42 weeks. 37 to 42 weeks is the range of the normal pregnancy, okay, then around 40 weeks. So before 37 weeks is a baby if is born, then that is called preterm, and after 37 weeks is term, and after 42 weeks is post-term. Then initiation of breastfeeding when it was done and no complications present. Then you take the nutritional history of the child. What did the child eat during the last 24 hours? What does the child eat usually, daily, and what did the child eat especially during the last 24 hours by the 24-hour recall method? I took the dietary history. So I saw what the child ate during morning, lunch and dinner. I calculated the amount. From there I calculated the energy and the protein intake. Okay, this you will learn during your family project classes. So ultimately we found that there was a deficiency in energy and protein as well. The energy was around 40% deficient and protein was 5% deficient. Then I took the anthropometric measurements, height, weight, mid-upper arm circumference, BMI, okay. Then head circumference and chest circumference. All these things are measured in case of under 5 child, okay. So weight is 9.4 kg, height is 87 centimeter, mid-upper arm circumference is 12.8 centimeter, head circumference is 48.5, chest circumference is 47, BMI is 12.5. So how do I calculate the BMI? So BMI is calculated, এটা কিন্তু অনেকে পরীক্ষার হলে বলতে ভুল করে, do not make a mistake. BMI is what? Weight in kg, height in meter square, okay. Kg by meter square is a unit. BMI is body mass index. So the weight, height, mid-upper arm circumference, head circumference, chest circumference, BMI. Now what is mid-upper arm circumference? Very good. তো তুমি acromion process বললে, olecranon process বললে. So acromion process, olecranon process তুমি কি করে, how will you measure, মানে how will you find out the points? এইগুলোতে এখানে এমন করে হাতটা বাচ্চা ঝুলিয়ে আছে, ঠিক আছে, it is not prominent, right? How will you, হ্যাঁ এরম ভাবে, you fold the elbow. So what happens is this acromion process and the olecranon process become prominent, otherwise it is not prominent, right? You make the child fold the arm like this, okay, the two bony prominences are there, you measure the length, okay, then find out the midpoint, mark the midpoint and see the circumference at that point. That is the mid-upper arm circumference. Now we can do it by normal measuring tape. This is a specimen that can come in your exam, that is the Shakir Tape, S-H-A-K-I-R, Shakir Tape, S-H-A-K-I-R, apostrophe S, Shakir Tape. Now what you can see, this is a color coded tape, right? There is a green color, yellow color and the red color. So what is the green color? Means the child is not malnourished, okay. What is the yellow color? It is moderately, mild to moderate malnourishment, and the red is severe malnourishment, severe malnourishment. So what is done is, at the mid-upper arm circumference, at the midpoint of the upper arm, the measurement is done like this. There is an arrow here, I think, yes, there is an arrow here, there you are measuring the circumference, okay. Once you are measuring the child's arm, you then fold it like this and find what is the circumference of the child's arm, okay. Whichever is there, it is in measured in centimeter. Now what is the normal? Because you can see there is a green zone, yellow zone and red zone, right? So green zone in the Shakir Tape, it is there between 12 and 13, okay, and the yellow zone and red zone, the demarcation is between 11 and 12. So it is told according to the Shakir Tape, below 11.5 is the red zone, 11.5 to 12.5 is the moderate borderline, and above 12.5 is the normal, okay. But that is for the people who are health workers in the field. So for surveillance, for monitoring and for screening of the children, that is used. Usually the classification of Malnutrition according to mid-upper arm circumference is below 12.5 it is severe malnutrition, between 12.5 to 13.5 it is mild to moderate malnutrition, and then above 13.5 is normal. In the book, in your book it is written and that is the correct classification. This tape, this demarcation is like 1 centimeter below the actual, but that is for the health workers to find out who are actually severely malnourished. Okay, severely malnourished. So here you can see the mid-upper arm circumference has been measured. Then there is the head circumference and the chest circumference. Why am I measuring the head circumference and the chest circumference? Any idea? We are measuring it because during the birth, the head circumference of the child is more than the chest circumference. But then as the child grows, if there is good nutrition, the chest circumference increases. At 1 year, both become equal, and after 1 year, the chest circumference is more than the head circumference. But if it is like, if the child has crossed 1 year, but the head circumference is still greater than the chest circumference, means there is malnutrition present. Okay, so you have to see like that. So here you can see the head circumference is more than the chest circumference still, and the BMI is low. So mid-upper arm circumference, head circumference, chest circumference, these are taken only in the case of children or under 5 children, okay, and not in adults. So now you are seeing the weight and the height, and now you have to plot the weight and the height in these charts. Okay, what is there in the, there is a x-axis and the y-axis. This is a WHO or Anganwadi or ICDS growth chart. Okay, this is a growth chart. WHO child growth standards is a growth chart. এটাকে বলে WHO growth chart is correct, or ICDS growth chart or Anganwadi growth chart. They are all correct answers because they are also, these charts are also present for each child in the Anganwadi center as well. There the growth monitoring is also done. So what you do, in the y-axis there is the weight in kg, in the x-axis there is the height. So at the age of, there is here 2 to 5 years, this chart is for 2 to 5 years. So at the age of 2 years, you are starting at the 0, okay, then you are seeing certain lines are drawn there, and with the increase in height, there should be increase in weight, okay, in that way the lines are going. When there is an increase in height, there should be an increase in weight. But why are the lines color coded? You have done the biostatistics class, right? Have you learnt about the Z score, Z value? Z value টা কি বলো? মানে Z score এর ফর্মুলা হচ্ছে x minus x bar, x minus হ্যাঁ, yes, x minus mean divided by the standard deviation. Very good. So what does this mean? Means how much is my height or my weight away from the mean height or weight I should achieve at this mean weight I should achieve at this height, and divided by the standard deviation. It is standard deviation, means I am standardizing that distance from the mean. So this is the mean. The mean weight that should be there at each height should lie on this green line, that is where the Z score is 0, the middle. At the middle of that bell curve, if there is a middle point, that is a mean point, okay. So that mean should be there. So at each height, the weight should lie on these points. Now there will be deviation. Not all children will lie on the 0, right? So I have to see whether they are going above or below. That is the trend I have to track from the birth till now. So there is the -1 Z score, +1 Z score, -2 Z score, +2 Z score, -3 Z score, +3 Z score. So the Z score value is seen in the growth chart. What in which zone it is lying and between which Z scores. So if the child is lying between -2 to +2 standard deviation, the child is within the normal weight for height range. if they are lying anywhere between the -2 to +2 standard deviation. But if they are below -2 standard deviation or above +2 standard deviation, means that there is either undernutrition or overnutrition. So between -2 to -3 there is moderate acute malnutrition, and if the child is on the -3 line or below, then this child is having severe acute malnutrition. MAM and SAM, moderate acute malnutrition and severe acute malnutrition. MAM child and SAM child. So the in which growth chart it is seen? It is for the weight for height growth chart. Keep in mind that there are 3 types of growth chart. The acute malnutrition, that is whether the child is normal or having moderate acute malnutrition or having severe acute malnutrition, it is plotted on the weight for height growth chart, and for it is different for boys and girls. The blue is for the boys. Okay. So because my child here is male, so I have used this chart and I have plotted the growth at this age where the child is, I think that is during middle. At that point the height and the weight. Okay, what is the height of the child and what is the weight of the child? As you can see, it is below the -3 line, means the child has severe acute malnutrition. Okay, the child has severe acute malnutrition. There is another type of chart called height for age. Second type of WHO growth chart is height for age, where the x-axis is the age and the y-axis is the height. Okay, before it was weight for height, where the y-axis was weight and x-axis was height. Here it is height for age, where the y-axis is height and x-axis is age. So at 5 years the child is there. At 5 years, where is a child lying? His height is again below -3. So this height for age charts, they signify chronic malnutrition. Height for age growth chart is for chronic malnutrition. So I will again write the weight for height or length, it is for acute malnutrition. The height for height or length or height for age is for chronic malnutrition. Why am I saying height and sometimes length? Here it is written only height, but for 0 to 5 years in the chart you will find it is written height/length, because below 2 years a child usually has only length, not height. The child is assumed to be not standing upright at that time, so the child is made to lie down and then measured between 2 boards what is the length. When the child is standing after 2 years, then that is called height. Okay, so below 2 years is the length, above 2 years is the height. Okay, so the weight for height or length chart is for chronic malnutrition, and the height or length for age chart is called for the chronic malnutrition, acute and chronic. Then what is the weight for age? Weight for age, these charts are there, it is like this. Okay, weight for age. So here the y-axis is weight, x-axis is age. It is for the monitoring of growth and overall status of malnutrition. The overall status of malnutrition, not acute, not chronic, just malnutrition is there or not. This is the mid-arm circumference. So then there is family history. Okay, whether the child has any stillbirth, there is stillbirth in the family, miscarriage, childhood death is there, or anomaly is there in the family, any risk factors. Then history of any TB, HIV, rubella, thyroid disorder in the mother, or TB, HIV in the family contact. Okay, and socio-economic status. What is the socio-economic status of the parents or the family? Okay, whether they are living below poverty line or above poverty line. and expenditure on education, expenditure on food, expenditure on housing, all this matters. What are the living conditions, etc. Any history of what is the history of housing, how is the housing or the environmental history, water supply, bathroom for sanitation purposes, whether there is any source of infection or contamination, okay. Sanitation, drainage, waste collection and disposal methods followed in the home, any history of domestic violence, gambling, addiction, contraception in family or not, what is the history present. So all these are risk factors because they can inadvertently affect the nutrition status in the child, all these factors. Now the general examination, what is that? There is the weight, height, head and chest circumference, MUAC, as we already saw. MUAC is the mid-upper arm circumference, okay. That is how the mid-upper arm circumference is measured by Shakir Tape. Then there is the generals and vitals like appearance. What is the child appearing to be? Alert, irritable, playful, okay, or lethargic. Any temperature is present in the child, high temperature. Then pallor, icterus, cyanosis, clubbing, pedal edema, lymphadenopathy, respiratory rate, pulse, okay. The head circumference, how is it measured? It is measured how? Children, what are the 2 points? Glabella, the occipital protuberance, the maximum circumference of the head, that is the head circumference, okay. Then there is head to toe examination, evidence of protein energy malnutrition is present or not, like eye changes in conjunctiva, cornea, dryness of the eyes or not, like xerophthalmia. Then skin infections are present or not, then dermatosis, hair changes, nail changes, brittle, ঠিক আছে ক্ষয়ে যাচ্ছে এরকম দেখাচ্ছে কিনা, pitting edema, edema is present in the dependent parts like the feet and the hands, okay, because when there is protein deficiency there will be edema in the body, okay. So evidence of rickets like pot belly, wrist widening, others, okay. There is delayed closure of fontanelles. In the diagram if you can see there is delayed closure of the fontanelles during malnutrition, frontal bossing, dental hypoplasia, pectus carinatum, swelling in the wrists and the joints. Then there is white sutures, craniotabes, rachitic history, Harrison sulcus and bowing of legs. So many other deficiencies of macronutrients and macronutrients, whether they are present or not, okay. You can find long eyelashes, brown hair, flax sign, easily what? Easily painlessly pluckable, flaky, plain dermatosis, all these things are there, so that you can find out whether there is any malnutrition in the child or not, okay. Any sign of measles, like what is there in the measles? Maculopapular rashes, okay. In the mouth what is found? So clinical diagnosis ki ache? 5 years old boy Siddharth Kumar, sons of these parents, they have achieved all developmental milestones according to his age. He is a case of severe acute malnutrition based on WHO growth chart, okay. This is my diagnosis of the case. So I have already spoken about this infection malnutrition cycle, okay. If there is inadequate dietary intake, there is weight loss, growth faltering, immunity lowered, mucosal damage, that in case can cause the disease, and disease can also in turn cause the appetite loss, nutrient loss, malabsorption, okay. When there is disease in children, they cannot absorb the food they are given, okay. The food intakes become less, that in turn again leads to malnutrition. So infection has a huge role to play in malnutrition. So early detection of PEM is basically by the health workers by usually the mid-upper arm circumference. Whatever I said, that is above 13.5 is a sign of satisfactory nutritional status, between 12.5 13.5 it is mild to moderate, and below 12.5 there is severe malnutrition, okay. আচ্ছা, যেটা আমরা বলেছিলাম যে if there is chronic malnutrition below -2 standard deviation, if there is malnutrition present in the height for age growth chart, then what I say is there is chronic malnutrition in the form of stunting, because the height for age is less, so there is stunting, okay. Stunting is an indicator of linear growth retardation. It results from the failure of receiving adequate nutrition over a long period of time. So it is not just happened right now. Okay, it is not an acute case, it is a chronic case happening over the past years. Continuous less receiving of the nutrition. So that is resulting in the chronic malnutrition or the stunting. So the height is not adequate of the child. Okay. So it often results in delayed psychosocial and cognitive development and poor school performance. So a stunted child has a height for a Z-score that is at least 2 standard deviations below the median for the WHO child growth standards. Okay. So this is height for age. Now the weight for height, that is for acute, if it is less than -2, it is called wasting. Okay. So wasting is a recent failure to receive the adequate nutrition. Okay, there is a recent either a bout of infection, okay, or it has recently the child has not taken any food, then that is the acute malnutrition or wasting, and may be affected by the recent episodes of diarrhea or other illnesses. And there is actual weight loss, and it causes include inadequate food intake, incorrect feeding practices, disease and infection, more frequently a combination of these factors. So that is why I asked all those history. The risk factors can start from birth. If there is a low birth weight, maybe high chances are there if the child is not receiving adequate nutrition, there is a high chance that the child will have this severe acute malnutrition in the future or this wasting in the future. So the wasted child has a weight for height Z-score that is at least 2 standard deviation below the median for the WHO child growth standards. So this is the weight for height. Here you can see it is below -3, that is why I have termed the child as severe, and it is acute malnutrition, so it is severe acute malnutrition. Understood? So what are the criteria for severe acute malnutrition? Very low weight for height or length, Z-score below -3 SD of the median WHO growth standards. Okay. It can be below -3 Z-score, that is one criteria, or if the mid-upper arm circumference is below 11.5 centimeter. Okay, severe acute malnutrition. If the arm circumference is below 11.5 centimeter, or there is a presence of nutritional edema, edema not resulting from other causes. If there is a presence of edema, especially in the limbs, then there is the diagnosis of severe acute malnutrition or SAM. So they are 9 times more likely to die. They are providing a major chunk in the child mortality, under 5 child mortality. So they can increase the case fatality in children suffering from illnesses like pneumonia and diarrhea. So if that child is then suffering from an infection, there is a high chance that the child will die. Okay. If SAM, then tell directly from the growth chart. For the moderate acute malnutrition, it has to be between, the Z-score must be between -2 to -3 standard deviation, and mid-upper arm circumference between 11.5 to 12.5 centimeter. And any systemic examination is there or not. So this is kwashiorkor and marasmus. Just you know this difference. The only thing I will just remind you is kwashiorkor is for what? You can see there is edema, there is pot belly. Okay. So there is the protein, mainly the protein deficiency in the kwashiorkor, and in the marasmus there is both the protein and the energy deficiency. So the child is lean and weakened. Okay. The ribs are protruding, they do not have edema. So that is the marasmus is the severe form of the the protein energy malnutrition. This kwashiorkor and marasmus do not occur in all maximum child. Maximum children will only present like a WHO growth chart less than 3 standard deviation, that's it. You cannot see that child like apparently that the child has any kwashiorkor or marasmus, but they will have certain features that is diagnosing the severe acute malnutrition. But the extreme forms are this kwashiorkor and the marasmus. So what is the different age group criteria for the protein energy ratio? The protein requirement is 0.95 to 0.91, energy requirement is 79 kilocalorie per kg per day and 68 kilocalorie per kg per day. So here you can see again the difference between kwashiorkor and marasmus is in the kwashiorkor the protein energy ratio decreases. Why? Because the protein decreases. That is why in kwashiorkor the protein energy ratio in the child is decreasing, but in the marasmus the protein energy ratio remains the same because both the protein and the energy are decreased in the marasmus. So this is the requirement that is given by the ICMR in 2020. So these are the requirements. If it is not meeting the requirement, there is high chance there is protein energy malnutrition. Okay. Then classification of the protein energy malnutrition. You may have read of it or may not till now. But there are 4 types of classification. There is the Gomez classification, Wellcome classification, then the Waterloo and the IAP. In your family logbook that is there, family care project logbook that I have told to bring, okay, in the একটা দেখো বলছি, in the under 5 child, after some pages you will find the under 5 children A1, A2, ঠিক আছে, before the diagnosis there is the nutritional status of the child are there, mid-upper arm circumference কত, weight for age কত, weight for height কত, ঠিক আছে, and the classification accordingly, ঠিক আছে, stunting আছে না wasting আছে এটা দেখে নাও। after দাঁড়াও তোমার দেখাচ্ছি, after the dietary history, food consumed by the family last 24 hours এর একটা পুরো food এর history আছে, right after that there is the under 5 children, under 5 health checkup, সেখানে দুটো তিনটে পেজ পরে গেলে লাস্টের পেজটায়, ঠিক আছে, ওই হিস্ট্রিটা নেওয়া শেষ হলে for that child there is the MUAC, weight for height, weight for age, okay, you can see the classification. So there you can see that Waterloo classification is given, okay, the Waterloo classification is given, that is in the column headings e ki ache, the weight for height, in the column headings there is given weight for height and in the row headings there is height for age, okay. Now I will classify whether the child is normal or just stunted or just wasted or both wasted and stunted, okay. So whichever category the child is lying according to the WHO growth chart, you will classify the child accordingly, the PEM. That is the Waterloo classification, and that is the classification of the child wasting or stunting, etc. But the if you want to calculate what percentage or what percentile the child is out of 100, then you can calculate the actual weight divided by the median weight for the height, like that. So in that case, if there is acute malnutrition, okay, if the child's actual weight for height is more than 90% of the median, then the child is normal. If it is 80 to 90%, it is mild, then moderate, then less than 70% of the median is severe. In the chronic malnutrition, if the child's height for age is more than 95% of the median, then it is normal, less than 95% is mild, less than 90% is moderate and less than 85% is severe. So this is the Waterloo classification. That is, I know there is stunting and wasting, but how severe? Mild, moderate or severe, or severe category. So that I can do by calculating the actual height divided by the median. 50th percentile means median, okay. Apart from the Waterloo classification, there is the Wellcome classification, okay, whether there is kwashiorkor or marasmus, okay. That is depending on the weight of the expected weight only. The Gomez classification is the depending on the weight for age, and the IAP means Indian Association of Pediatrics, IAP. This IAP classification is again weight for age. So weight for height category is only considered in the Waterloo classification usually. So the severity of the malnutrition can be classified by any one of that. Usually nowadays we classify by Waterloo classification or IAP classification, okay. Now we are coming to the NRC or the Nutrition Rehabilitation Centers, Nutritional Rehabilitation Centers. Now whenever you are finding a SAM child in the community, you have to refer them to this NRC or the Nutritional Rehabilitation Center. ঠিক আছে? So it is the factor of most deaths among the children suffering from these common illnesses. So there are facility based units providing medical and nutritional care for SAM children under 5 years who have medical complications. Now SAM children having medical complications, they should be referred to this NRC or the Nutritional Rehabilitation Centers. In addition, special focus is on improving the skill of the mothers on the child care and feeding practices, so the child continues to get adequate nutrition at home. Okay. So what is done? 24-hour care and monitoring of the child at that center, treatment of medical complications, any complications the children has developed during that malnutrition phase, therapeutic feeding. Feeding is there, but it works as a medicine. Okay, so therapeutic feeding, sensory stimulation, emotional care, counseling on how to feed, appropriately feeding, care and hygiene, demonstration and practice by doing on the preparation of energy dense food, how to prepare energy dense foods for the children to have, okay, from the locally available food source. Then social assessment of the family, whether the child will remain in a contributing a good environment at home or not. So the social factors and follow up of the children discharged from the facility. So there is the management of the SAM child that are divided into two parts, the medical management and the nutritional management. Now usually both go side by side. Medical management means giving medicines to manage their complications, but nutritional management is whatever diet is provided to the child. First step, when the child is arriving to the NRC, there is emergency triage and treatment, then check airway, breathing, circulation, etc. The CABC of the management, okay, and assess circulation for shock, check for coma and ongoing care, whether there is convulsion or any danger signs are present in the child or not. You have to assess that first. Then in the nutritional, under the nutritional care, we are going to the first phase, that is the stabilization phase. So stabilization phase, what is that? In the child where there is severe acute malnutrition with no appetite and there are major medical complications, that child is then now coming into the stabilization phase, the first phase of the nutritional care. So broad spectrum antibiotics, early initiation of therapeutic food. What is this therapeutic food? It is a diet called F75 diet. F75 diet is 70, why is it 75? Because there is 75 kilocalorie in 100 ml of the protein, 100 ml of the food with protein 0.9 gram per 100 ml. Means for the 100 ml of the diet, there is 75 kilocalorie of energy and 0.9 gram of protein. Why am I starting with this small, it seems like a very small amount of calorie and protein. Why? Because the child at this stage cannot feed much, but you have to start the feeding. So this therapeutic feeding is started with the F75 diet, that is low feeding, that is low quantity feeding, so that the child starts to take the nutrition, because beyond this the child will not tolerate any nutrition. The child has malabsorption at this point. So that is why in those children who are presented with complications, you have to start them a little with F75 diet, that is in the stabilization phase. It lasts 1 to 2 days and promotes the recovery of normal metabolism. So this malabsorption and abnormal metabolism phase needs to be taken care of first, so that the child starts taking the food normally after 1 to 2 days. And because the child has in the complications or in the severe acute malnutrition phase many electrolyte disbalances as well, so this manages the electrolyte disbalance in the stabilization phase. So all these 10 activities are done. This is from Harrison. All these 10 activities are done in the severe acute malnourished child. That is hypoglycemia, hypothermia, dehydration. These are basically, these three are taken care of during the stabilization phase. Hypoglycemia, hypothermia, dehydration. Then there is electrolyte disbalance, infection can be there, micronutrient deficiencies can be there. So it is starting again, the electrolyte disbalance is starting in the first 1 to 2 days. You are treating the infection as well. Okay, start treating the infection with broad spectrum antibiotics. And the micronutrient deficiencies, you do not give iron at this phase, otherwise other macronutrient deficiencies are this treatment is provided. And you begin the feeding by F75 and stimulate emotional and sensorial development. but not other things. Okay, not other activities are done, these activities are started with. So hypoglycemia, then the hypothermia, dehydration, electrolyte disbalance and starter feeding, these are all started at the beginning mainly for the 1 to 2 days. Then comes the transition phase. Next day 3 to day 7, okay, there the child is going to the transition phase. When will I start the child on transition phase? When there is at least beginning of the loss of edema and return of appetite and no nasogastric tube infusions, no severe medical problems, and is alert and active. So if the child is beginning to lose the edema, the major complications are and infections are managed, okay, the child is able to take the food, they are wanting food again, there is regain of appetite and the metabolism is restoring to normal and the child has become alert and active, then the child will start the transition phase. So it lasts from day 3 to day 7. If the child can tolerate increased protein energy intake, now if the child can tolerate the food they are given, then you are increasing the energy intake and the protein intake of the child by F100 diet. This is a catch-up diet. It is called a catch-up diet, not the starter diet. Starter diet is F75, now there is catch-up diet. So F100, that is energy that is providing 100 kilocalorie per 100 ml and protein is 2.9 gram per 100 ml. So this F100 diet is now given. Finally, the rehabilitation phase. Now when the child has reasonable appetite, finishes more than 90% of the feed given without a significant pause, there is no edema now, loss of edema is or major reduction of edema and no other medical problems are there, child has regained the feeding habit, then you have to rehabilitate the child to normal food now, okay, to normal food. So rehabilitation phase is then started to promote rapid weight gain, stimulate physical and emotional development, then lasts from day 8 till 2 weeks. So the whole treatments last for like 21 days or 3 weeks. So first 1 week is there is stabilization and the transition phase, and then from the second week there is a rehabilitation phase. Introducing normal semi-solid to solid food in the diet now, okay, and preparing of the normal feeding at home. At this point the mother isn't taught how to prepare the feeding, what to feed the child at home, how to identify the danger signs, how to feed the child so that this doesn't happen again, okay. In the follow-up, child enrolled in Anganwadi center, home visits by Anganwadi workers for weight monitoring, feeding and counseling. So in this way a child is then restored to normalcy after severe acute malnutrition. This NRC treatment, this whole phase is under NRC. So this is one of the examples of F75, F100 diet, these come in packets and they are used at NRC. So children with the SAM should be discharged from the NRC only when their weight for height or length is at least more than -2 z-score, when the weight for height has restored a bit and they have no edema for at least 2 weeks, or the mid-upper arm circumference is more than 12.5 millimeter and 12.5 centimeter and they have no edema for the last 2 weeks. So either they have regained their weight for height or they have increased the MUAC and there is no edema. So that is the discharge criteria. And the mother should be counseled on appropriate feeding to give appropriate meals at least 5 times daily, give high energy snacks between the meals like milk, bread, banana, biscuits, assist and encourage the child to complete the each meal and give food separately to the child so the child's intake can be checked, and breastfeed as often as the child wants. If under 2 years, the child will be breastfed until the child is demanding, okay. So the feeding should be appropriate and the feeding should not be less because the child has to maintain that status, that nutritional status, okay. This is the I think the home management. These are again a detailed advice. There is the immediate advice, long term advice. In the table what is there is the normal complementary feeding criteria. What should be given to the child? Up to 6 months there is exclusive breastfeeding. Then 6 to 9 months complementary feeding is starting with lumpy feeds, with semi-solid lumpy feeds, introducing one new food at a time like khichdi or dalia. Gradually increase the amount to include the cereals, green vegetables, okay, lentils, oil, ghee, mashed dal, hard boiled egg. So mashing the food and giving it in lumps or semi-solid. Then at 9 to 12 months, at least half cup food needs chewing 3 to 4 times a day with 1 to 2 snacks in between. And in the second year, 13 to 24 months, introduce the family food and increase the cup to 3 to 4 times. So that 3 to 4 times a day, 1 cup of food is consumed by the child. So that is the adequate gradual introduction of complementary food, and at the end of 24 months, the child is introduced to proper food that is consumed by the family members as well, and the breastfeeding is stopped, okay, at the end of 2 years. So that is for the individual level. You can depending on the age of the child, you can advise like this, okay. Then long term management, personal hygiene, vaccination, breastfeeding, weight monitoring, Anganwadi service utilization, IFA, vitamin A supplementation, all these things should be going parallelly. In the family level, for the family members, what you can advise them, there is the complementary feeding, how it should be done, okay, vaccination, any family planning choices. If there are many children, now is a time for introduction of family planning services, that how to maintain the small family, and importance of birth spacing, importance of sanitation, then consumption of fortified food, means food fortified with vitamin A, iron, okay, vitamin D. So good nutritional quality foods, and correct the wrong cultural practices regarding food, that is giving prelactial feed, okay, that is one wrong cultural practice. So eating junk food, lactation failure, and broken family, problem family, all these things should be managed. Community level, health and education, nutrition, sanitation facilities, growth monitoring, if the Anganwadi service is working or not, if the Anganwadi center is working or not, in that way you can manage the malnutrition problem at the community level, because this is a huge public health problem, and that is a leading cause of death, okay, in children. So that is why this cause should be tackled in all the levels. Understood? So you are now familiar with the mid-upper arm circumference, how to measure, Shakir Tape, the WHO growth charts, and how to determine whether the child is suffering from severe acute malnutrition or not, okay, and what is the management in the NRC, okay, chalo, thank you.